Hello and welcome to the Nursing Economics podcast series. This series provides extended content relating to articles published in the journal, such as interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off your first-year subscription to Nursing Economics. Simply visit nursingeconomics.net/offer to take advantage of this special discount. The nursing community has a unique opportunity to inform the public and policymakers of the vital role nurse practitioners play in advancing health access, equity, and quality care. Recently, Becker's Hospital Review published a notice stating about 15 physicians at Edward Elmhurst Hospital were to be terminated and replaced by nurse practitioners. The implications made in response from local physician groups were that nurse practitioners are viewed as mid-level providers, and this practice could put patients in danger. In response, in December 2019, nurses from Rush University College of Nursing and Rush Health in Chicago submitted a letter to the editor to Becker's Hospital Review, expressing dismay at the description of nurse practitioners as mid-level providers. The Nursing Economics Editorial Board believes all nurses have an ethical obligation to correct inaccurate descriptions of advanced practice colleagues, and in support of the nurses from Rush University and Rush Health, submitted a follow-up letter to the editor to Becker's Hospital Review. Today's discussion, led by Nursing Economics Editorial Board member Dr. Therese Fitzpatrick, focuses on the events at Edward Elmhurst Hospital as reported in Becker's Hospital Review, and elaborates on why advanced practice registered nurses and nurse practitioners must become informants to policymakers and the public. As the nursing profession around the world celebrates 2020 as the Year of the Nurse and Midwife, participants in this discussion share the profound impact nurse practitioners make in the healthcare arena, both nationally and globally. We are pleased to introduce Dr. Therese Fitzpatrick, who will lead this important discussion.
Good afternoon. This is Therese Fitzpatrick. I am a member of the editorial board for the Journal of Nursing Economics, and I have the pleasure today to be sitting with a group of our colleagues at Rush University. It is so appropriate that we be having this conversation in the Year of the Nurse and the Midwife. 2020 is the Year of the Nurse and the Midwife because our colleagues have really come out in a very, very courageous way and are having and actually leading the conversation, certainly here in Chicago, but across the country in terms of advanced practice nurses, how we think about ourselves, how we refer to ourselves, both in the media and with our clinical colleagues. So I would like to introduce those of us in the room. We have with us Dr. Lynn Braun, who's a professor emerita at Rush University in the Department of Adult Health and Gerontological Nursing, and she is also a consultant in the Rush Heart Center for Women, where she is a nurse practitioner. Dr. Braun's clinical and research interests include cardiovascular risk reduction, exercise, cardiac rehabilitation, hyperlipidemia, and hypertension management. So welcome, Dr. Braun.
Thank you.
Also with me at Rush University is Dr. Rachel Ferry-Rooney, who is an adult nurse practitioner with over 20 years of internal medicine experience and currently practices clinically in 2 school-based high school health centers in Chicago. She is an assistant professor in the Department of Adult Health and Gerontological Nursing at Rush University. She also sits on the board of directors of the Illinois Society of Advanced Practice Nurses, which represents the professional interests of APRNs to state government in Illinois. Also with us is Dr. Angela Moss, who is a faculty nurse practitioner, assistant professor, and the assistant dean of faculty practice, where she leads over 40 community-based faculty nurse and nurse practitioner clinicians providing care to Chicago's most vulnerable populations. Dr. Moss is an expert in the care of underserved populations through nurse-led programs, strategic development of nurse-managed care delivery models, and programmatic and outcome evaluation, and she currently practices clinically in a nurse-managed health center for formerly incarcerated men and women. Welcome.
Thank you.
Also with us is Dr. Terry Gallagher, who is a family nurse practitioner and the Director of Generalist Education at Rush University's College of Nursing. Dr. Gallagher established a community clinic serving low-income individuals on Chicago's West Side about 5 years ago. Dr. Gallagher, welcome.
Thank you.
Let me sort of set the context for our conversation this afternoon. In early December, the Becker's Hospital Review, which is a newsletter that sort of goes out to healthcare leadership across the country, published an article that was entitled Edward Elmhurst Health System to Replace Physicians with Mid-Level Providers at Their Immediate Care Sites. So what I would like to do, because I would like to have the article read into our transcript so that you have an understanding of what was sent across to healthcare providers and leaders across the country. And then we'd like to spend the rest of our conversation this afternoon talking about the really courageous and important response that our colleagues here at Rush wrote and sort of the response and a little bit about what's been happening since then. So, Dr. Braun, if I could ask you to please read the article into our conversation.
Sure. We just heard the title, which once again is Edward Elmhurst to Replace Physicians with Mid-Level Providers at Immediate Care Sites. The article goes on and states, due to budget constraints, Chicago area health system Edward Elmhurst Health reportedly plans to lay off 15 physicians from its immediate care clinics next year and replace them with nurse practitioners, sources told Becker's Hospital Review. At what initially appeared to be a routine staff meeting on November 19, 2019, physicians learned they would lose their jobs next March, according to a physician affected by the cuts. The physician spoke with Becker's on the condition of anonymity. Quote, "This is what we are facing now, that physicians don't have job security. That cost is becoming more of a priority than patient care and safety," unquote, the physician said. The physician is part of an organization called Physicians for Patient Protection, which advocates for physician-led care. After March 31, 2020, the health system's 7 immediate care clinics will be staffed entirely by mid-level providers, according to the physician. He states, "At first it was a little disappointing, and then you start worrying about patient safety. You think about all the unusual and complex patients that you've had, and then you wonder if someone with lesser training is going to pick up on some of the subtleties," unquote. Nurse practitioners in Illinois are required to hold a registered nursing license in the state, complete a graduate nursing program, earn a national certification, and apply for an advanced practice registered nurse license. Graduate nursing programs must provide a minimum of 500 hours of clinical care experience. This training allows NPs in Illinois to work in a collaborative practice agreement with physicians, which does not require the physician to be present. APRNs can apply for full practice authority in Illinois, meaning they can work independently of physicians after completing at least 4,000 notarized hours of clinical practice under physician supervision. Edward Elmhurst Health System's Director of Public Relations, Keith Hartenberger, provided the following statement regarding the decision. "We continue to assess our care delivery models in the interest of providing cost-effective care to our patients. We shared with physicians that we have plans to change the model next year at some outpatient sites and are working with anyone affected to find alternative placement." When asked to confirm the number of physicians affected, Mr. Hartenberger directed Becker's back to the previous statement.
Thank you. So again, I wanted to point out that this article within this newsletter has thousands of readers across the country. Dr. Moss, can you talk to sort of what was the response here among your faculty colleagues at Rush? And then I would love for one of you to read your response to this article into our transcript this afternoon.
Thank you, Teresa. This is Angela. So one of the overwhelming initial responses was that of our faculty, NPs, and NP clinician colleagues in the medical center objected to the use of the term mid-levels. So at the same time, we kind of became organized as a group to write a response to the editors at Becker's. So I'd like to read that,
please,
and then we can talk about it a little bit more. So the initial piece came out in Becker's December 2nd, I believe, and then our response came out on December 11th. So it was a pretty quick turnaround time. And this is what Becker's published. So it's titled, Letter to the Editor, Nurse Practitioners Are Not Mid-Level Providers. And it goes as follows. 15 physicians are expected to be let go from the suburban Edward Elmhurst Hospital in the next year, as reported by Becker's Hospital Review. These physicians, who work in immediate care clinics, will be replaced by nurse practitioners. This has understandably upset physicians, and hearing of anyone losing their job is distressing. But as a group of nurse practitioners, we take umbrage with two things. One, the use of the term mid-level by Becker's, and two, the implication patients are being put in danger by this decision. The term mid-level is outdated and derogatory toward nurse practitioners because it suggests that the care they provide is not high level. Nurse practitioners are trained at the master's and doctoral levels, are visited 1.06 billion times a year by patients. In addition to being healthcare providers, nurse practitioners educate, innovate, conduct research, and are involved with the development of health policy at the state and federal levels. Since the introduction of the role of the nurse practitioner in 1965, researchers have rigorously studied the quality of care nurse practitioners provide as well as their outcomes. This large body of research has consistently demonstrated that nurse practitioners provide safe, effective, patient-centered, timely, and efficient care. A 2014 study demonstrated a link between nurse practitioners having full practice authority and a decrease in readmission rates for Medicare/Medicaid patients. Readmission rates are one of the quality indicators CMS uses to gauge the safety and efficacy of hospitals. A 2012 study from Australia demonstrates similar patient outcomes between physicians and nurse practitioners in a fast-track emergency department, although the nurse practitioners had higher patient satisfaction rates. Similarly, in critical care settings, the nurse practitioners have demonstrated improved time to consultation and treatment, improved mortality, cost savings, and patient satisfaction. Nurse practitioners are 25% of healthcare providers in rural America, where access to care has been a longstanding problem and healthcare providers are desperately needed. The number of nurse practitioners in rural practice settings increased 43.2% between 2008 and 2016. Nurse practitioners also fill critical healthcare gaps in densely populated areas, and particularly so among the most vulnerable, such as low-income families, immigrants, and persons suffering from homelessness, mental illness, and substance abuse. In Illinois, approximately 50% of the nearly 4,000 Illinois licensed nurse practitioners provide care in the Chicago metro area and do so among some of the city's neediest populations. The high-quality care that nurse practitioners bring to healthcare was recognized by the Department of Veterans Affairs in 2016. The VA announced full practice authority for advanced practice nurses, joining the now 20 states with full practice authority in the United States. With this policy change, the VA recognized that nurse practitioners provide safe and effective primary care while improving patient access to care. To be sure, all members of the healthcare team are valued and indispensable to producing excellent outcomes for our patients. We are disappointed our physician colleagues have been laid off, as many of us work alongside physicians in equitable practice settings. But the care nurse practitioners provide is not mid-level, nor are we physician replacements. We have our own clearly defined profession, and our goal is to provide the highest standard of care to patients, whether that is inpatient or outpatient, rural or urban areas. There is plenty of work for us all. Our patients need us.
Thank you. What a powerful response. And we'll talk in a minute about how Becker's dealt with your response. Rachel, could you talk a little bit about what happened? You all see this article come out in Becker's. How did you organize the response here at the college that was just read by Angela?
It was actually initially, not all of us get Becker's, and so the Becker's article was made aware to all of us through university marketing, and they sent it out and knew that there were a group of us that have been active in writing op-eds and have in fact been trained in writing op-eds. And so they sent out a request to see who might be interested to respond. And very quickly, there were quite a few of us who were more than just the four of us here as well, who were interested in responding. Because we had been trained by a program called the Op-Ed Project, most of us anyway, we had the tools to be able to quickly respond, know that timeliness was important, know how to write the article in such a way that it would pull in some of the things that a publisher might be looking for, as well as respond in the way that we wanted to respond. And so we were able to quickly start writing it and get that put on paper and then sent out to all of us multiple times so that we could quickly add our 2 cents and 4 cents and our dollars in there and then create our response.
Great. Thank you. Any other thoughts from the group before we move on?
I was just going to say,
Yeah.
I think that I just want to underscore the fact that we mobilized very quickly.
Yes.
Mm-hmm.
And we were on the same page from day one. So and when I hear it again, when I hear the response again, you called it powerful, and I truly think that that's what it was.
It really is.
Yeah.
Yeah.
And this is Angela. I want to add the training that we got from the op-ed project. I really attribute a lot of our ability to mobilize around that training, because what I took away from it is almost, I'm doing air quotes here, like media readiness is really important. So being able to recognize when an opportunity presents itself, to have a voice and be an advocate for the nursing profession, for nurse practitioners, for really for anything, is you kind of have to follow the news cycle and be ready to jump in there. Because when you hold back, the news cycle moves on without you. You kind of lose that opportunity. So that's how we were able to get in there. We mobilized.
Great. Well, thank you. So, Terry, would you offer a few thoughts about why this response was warranted? Sort of why did you need to get on top of this as quickly as you did?
Yeah, so as nurses and as faculty in the College of Nursing, I think we all are very passionate about providing education to everyone, and we also are very passionate about dispelling myths and misconceptions. So in the original article, there are lots of errors and inaccuracies that we felt it was very important to address. If a layperson were to read that article, I think that they may be confused or even fearful that their health is at risk when it isn't. And I think that is what's implied in all these articles, is that the debate between physicians and nurse practitioners is about patient safety when it's really not. That is not what this debate is about. The group that was quoted in the article is the Physicians for Patient Protection. That is a clever name. And it seems that their interest, because they are a special interest group, that their interest is protecting patients, but I think their interest is protecting themselves and their livelihoods. And there was also an article that came out recently from the Chicago Tribune that featured a headline mentioning nurse practitioners' independent practice authority, and the headline ended with the question, should you be worried? And again, if the implication is that patients are being harmed, I think it's very important for us to speak up and to assure our patients that they are safe, that the nurse practitioner outcomes are excellent, and that our patients will benefit being under the care of nurse practitioners.
Thank you.
If I could,
yes, please.
Go ahead. Go ahead, Lynn.
This is Lynn. I just wanted to tag on to that. The fact that many patients choose nurse practitioner care. And that's really an important note, and I witnessed this very recently because I retired from both my academic and my practice positions, and so as I was in the process of transitioning my patients, because of what their health issues were, sometimes it made sense for me to transition a given patient to a physician. And by and large, my patients who I tried to do that with would say to me, but who will be my nurse practitioner? They see the difference in care, and they know that their outcomes are excellent. And they choose, they choose to be cared for by a nurse practitioner.
This is Angela. I wanted to add one other thing, too, like why is this response warranted? And I want to reference the Woodhull study, which is about nurses' voice in the media. And so just quickly recapping, in 1997, the Woodhull study did an evaluation of nurses that were quoted in media in articles about healthcare. And at that time, in 1997, it was found that nurses were quoted only 4% of the time. And so that's pretty low, considering that nurses are the largest healthcare workforce and
the most trusted.
Most trusted, all of the things, excellent outcomes, all of the things we know about nursing. So at that time, there was a push to increase nurses' voices in the media and so on and so forth. And in 2017, the Woodhull study was revised and they reevaluated. And guess what? They found that the incidence of nurses being quoted in articles went down from 4% to 2%. So why was this response warranted? And I really feel that if we don't fill that voice, if we don't answer the questions, then other people will, and it won't necessarily be the message that we want to have out there, and other people will fill that space. And it'll be other people, and by people I mean other professions, other media, whatever, fill in the blank, will be talking about nurses instead of talking with nurses or to, So that's why we felt compelled and why this response is important, not only for public, but also for other nurses and nurse practitioners. We help them lead the way.
Thank you. Lynn, federal regulations, specifically Section 1300.01, provides a definition of, quote, mid-level practitioners, which includes those providers that are not physicians, dentists, veterinarians, etc. Is this definition adding to the confusion or lack of clarity regarding the actual role and capabilities of APRNs?
Thank you, Therese. The answer to that is a resounding yes. Of course, it's adding to the confusion. I suspect that the government wanted to place nurse practitioners and physician's assistants into the same bucket. They didn't want us to have our own name necessarily. They wanted to group us under the term mid-level provider, meaning that we're not physicians, and implying that our care is somewhere lesser or in the middle, which couldn't be further from the truth. So that's just a wrong thing to do. We have titles that we've earned. We have roles that we've earned. We are nurse practitioners. Physician's assistants are physician's assistants. Our educational models are very different from one another, and it's probably why a patient may choose a nurse practitioner because of the way we practice. And the term mid-level provider has been opposed by our largest organization, the American Association of Nurse Practitioners. They have a statement on their website that strongly opposes mid-level provider in reference to nurse practitioners. And they cite that the Institute of Medicine in 2010, in their blueprint for the future of nursing, state that nurse practitioners should be full partners. Let me say that again. Full partners with physicians and other healthcare professionals. That doesn't mean we don't collaborate. If Angela and I worked in the same clinic, we would be collaborating with one another. Similarly, with any physician that worked in that clinic, we collaborate. Nonetheless, we are full partners in that setting. So I think that's really very important, and that's key.
Thank you. Any other thoughts?
I think it's important to remember where these terms are coming from, and a lot of laws are written by lobbyists and special interest groups. I'm having trouble thinking of another time where one group has a name that they chose for themselves, which is a nurse practitioner, and someone else has told them that they have a different name, which is a mid-level provider. And so it is not a name that we've agreed to. It is not a name that we've chosen. But yet in these laws and in medical institutions, that is what we are called. And I think it's important, again, for us to advocate for ourselves, to rewrite these laws. Laws are revised all the time. and then also to educate people who are in a position in medical institutions that this is not a title that we have chosen, nor that we agree with.
You know, and if I can add to that, this is Therese. It's important for all of us as nursing leaders, whether we be chief nurses within an organization, system chief nurses, or any, sort of leadership role within the organization, that we correct this conversation when it's happening. And we often do. We may have difficulty sort of finding our voice, particularly we're in a large group, perhaps collaborating on certain aspects of care, and one of our colleagues, a physician or a PA colleague, will use that term. We have a responsibility to find our voice and be very courageous and be able to speak in an informative way, sort of what the correct title is and why it's important, and to do so from a way, as all four of you have discussed so eloquently here this afternoon, that it's really about patients and patient safety and not frightening patients. So if any of you have any thoughts about that, how might we have that conversation? So let's, for the sake of an example here, we're all sort of sitting in a committee meeting and one of our colleagues uses the term mid-level practitioner. How would you counsel those of us as nursing leaders to respond to that in the moment?
This is Lynn. I'd like to answer that because I've had that conversation probably 100 times. Yes. I think, first of all, it depends on the situation. It may not be appropriate to say, excuse me, our nurse practitioners are not mid-level providers in the course of that meeting, depending on the context of that meeting. But it is up to us afterwards to whoever said that and perhaps to clarify it in the minutes or in whatever would be a respectful way to be sure that that person understands that is not acceptable terminology and why it's not acceptable terminology. And I don't care who that is. I don't care whether it's the president of an organization, the head of a university, a drug rep, or whomever. So many people could be using that term, and they are using that term. And if that is something that is considered a label that a whole organization uses for nurse practitioners and physician's assistants, then it should be the job of a group of nurse practitioners to take that up the channel and figure out the best way to make, to change, how change will happen in that particular organization. Because most organizations have moved away from that now, but there are some left that haven't.
And actually, this is Rachel, I'd like to add to that. I think also, even if it's not within your workplace, social media is a place where there's a lot of conversation about this. And what I've done is I've started, directly responding back to whatever post it is that uses either mid-level or other terms, physician extender, and correcting them then and there. It's one of our favorite terms there, physician extender, not favorite at all, in order to respond right away and say, no, this is not correct, and here's why, and then, to link it, through, if it's Twitter, through a hashtag or whatever, to be able to direct people to other places where they can get more information if they want to. So I will often start to formulate a response and then actually stop and go look up the link so I can put it in if there's a link that's immediately relevant to the conversation. So I think social media is a place that we really need to also use our voice and make sure that we're correcting people's terminology.
Yeah, say that Rachel does this very well, because just in the last 48 hours, I saw your response on Doximity to an article.
And then if I could add, this is Angela, if I could add on something as well, I think one of the things in our response, so I too have had many of those conversations when we're in meetings, back to the original question, Teresa, where somebody uses the term and what do you do? So my approach has typically been to not publicly shame the individual, but to wait and have a one-on-one conversation with that person. But my goal and a challenge that I've always found is that I want to be respectful of that person's opinion and where they might be coming from, trying to understand where they're coming from. I want to make sure that my education that I'm providing to them about not using the term mid-level is measured and data-driven, and that I remove the feeling from it. So it's not like an emotionally charged conversation, but more a peer-to-peer, colleague, professional kind of teaching moment. And I think that that's why our piece in Becker's was so powerful. And that's what people have said about it. They've said, oh, that was really, it wasn't complaining, or it wasn't, it was a reaction, but it was measured. And it was done in a way that was data-driven, that removes the emotion from it. So that would be my advice, is to try to stick to that, because you don't want to get into the loop of, oh, those nurse practitioners, they're always complaining. They're never happy with what, you know, you don't want to feed that kind of dialogue.
Not at all.
So
So not
keeping the emotion out, and actually, one other thing I should say is that one of the things that this piece, so our piece in Becker's was a reaction, but I think it has given us, because of some of the attention that it's gotten, it's given us the opportunity to become more proactive, so to get ahead of the news cycle and try to get positive, so we control the narrative rather than other people talking about us, and instead we're talking about ourselves, and or other people naming us. No, we are naming ourselves, and we are kind of taking over that dialogue. So, and that's what the podcast is about.
Exactly. And, you know, I'm sorry. Please,
go
ahead.
I was just going to say that what we have to change is the fact that, for the most part, we're speaking to the choir. You know, we speak to other nurses and nurse practitioners. And we have to make sure our voice is out there in other types of media where others will read it, and especially the public. Especially the public.
If you could speak to the response from Becker's. So the original news article comes out. You very quickly were able to mobilize a response here at the university, and you had very positive interactions from Becker's. Would you mind speaking to that?
Sure. This is Terry. I sent it to the editor of Becker's, and she responded very quickly and said that she was not aware of the controversy around the term mid-level provider, and that the reason it was used in the article was because it had been used by the representative for Physicians for Patient Protection. And she had shared our letter with the editorial board of Becker's and said that they were looking at ways to change how they were going to report on nurse practitioners, and especially on the debate between physicians and nurse practitioners, and ensured that it's even and measured.
Which sort of gets to the point, Lynn, that you had made, that we can't continue to have internal dialogue preaching to the choir, right? We know this as leaders within the profession, but it matters when you get that word out and have that conversation outside of nursing.
This is Angela, just adding on. The response that we received from the editor was wonderfully eloquent and thoughtful, and really apologized. I'm so sorry, I didn't know, and because of your response, we are going to change the way we are reporting about nurse practitioners going forward. So that feels amazing.
And it feels really is. It really is. The courageous voice does matter. It really does. It makes a very big difference. You know, before we sort of leave the conversation around the media, as we were gathering here this afternoon, several of you mentioned this notion about some of these terms sort of being clickbait, is what you referred to it. So these very sort of provocative sorts of terms, often they truly are clickbait, and you identified some of those. Could you talk to that and how we might as nurse leaders respond to that?
So this is Terry again. I mentioned earlier that the recent article from the Chicago Tribune asking if people should be worried. Anytime a Physicians for Patient Protection was quoted in the article, they had no data, and they kept saying, "We just are worried. We just are worried. We're so worried about this." And it goes back to what Angela was saying about how a lot of these articles are emotional, they are inflammatory, And it's really important not to respond in kind and to take a measured response. Our entire practice is driven by data and evidence. So that's what we're bringing to these responses, to these op-eds, because you can't say, that you're worried about something and you first have no proof that it exists in the first place and that there is any proof, to have anything to worry about. Mm-hmm. And again, it's fear-mongering for the sake of, I do believe this all comes down to finances and to revenue, Yep. And it's not really about the safety of our patients.
Mm-hmm. Some of the physician-led articles will say, there's data that nurse practitioners order more diagnostic tests than physicians do. Mm-hmm. So that means that they're more unsure of, of what to do.
Mm-hmm. But maybe, Lynn, we are seeing nurse practitioners often treat people who are uninsured, who are underinsured, because physicians have been known to choose to stick with commercial insurance.
Yes.
And so possibly we're seeing patients who are sicker, who have not had care in years, and that extra diagnostic testing is warranted.
Yes. This is Rachel. I don't have the data to be able to quote it for you in front of us, or right now in front of us, but I do know that, in fact, that we do not order more tests. Mm-hmm. In fact, we order less tests than the average physician. And so I will get that reference for you so we can include it.
Great. Thank you.
Yes.
Thanks.
Because it's absolutely not true.
Yes. Mm-hmm. Yeah. I'd like to come back, Terry, to a point that you made a minute ago, and the importance of why we APRNs must become informants to policymakers and to the public. And if you could all sort of speak to the importance of that as it relates to billing, because you have done so much work around, equitable billing for these patients along with our medical colleagues. It's important that policymakers understand this. So could you, I know you are very involved with your professional organization, both at a national level and certainly here in the state of Illinois, if you could speak to that, sort of the interactions that you are having with policymakers, that'd be really helpful for us.
So this is Rachel. I can actually speak to that. So, we have to remember that our legislators are not physicians. They're not nurses. They're typically not healthcare providers at all. And they don't have the information that we have. And unless we go and we talk to them, they are not informed. And how they are informed is by whoever tells them what they want them to know. So if our voice isn't heard in Springfield here in Illinois, isn't heard in Washington, D.C., or anywhere else that our legislators are sitting, then we aren't part of the conversation and someone else is. Mm-hmm. And it's really important for us to be able to inform our legislators of what we do, why we do it, how we do it, which is the data-driven piece that we've been talking about, and to really be able to show why it's important for nurses and nurse practitioners to be recognized by our legislators as an important piece of the healthcare team. And the other piece that I think is really important to remember is when we're going and talking about the terminology, so this mid-level provider piece, I suspect it was not written to belittle us, but to make it easier for someone else to call us by something. And so then it gets written into a government document and then gets picked up and starts being used. So the only way we can fix this is to re-educate the people who are doing this writing. And, of course, they're on the government level. And so for us to be able to reach out and re-educate the legislators and the people who are writing bills for the legislators, that is really important to be able to fix that. We saw this actually with Medicare and how they were making physicians, actually, how they were making healthcare providers who took students, how they were making the documentation different, the requirements different for medical students and for residents and interns versus nurse practitioner students. This was, I want to say 2018. And so they didn't have the information to really include nurse practitioner students in the process of saying that it was not necessary to rewrite the entire note as a provider. So if I'm the provider taking a nurse practitioner student, I'm required to this day to rewrite their entire note. What this has done is this has made it so that we have lost preceptors in the educational setting because preceptors don't want to have to rewrite the note of someone that they're working with, usually by, because writing legislation is hard. And if we're not in the lens of our legislators and the people that are writing legislation, they just simply forget sometimes. And we need to make sure that we're remembered.
If I can add, this is Angela, if I can add on it, the take-home message for me is that we're not going to get an invitation to come and talk to maybe once in a blue moon. People, a congressman or somebody will reach out and say, hey, I'd like a nursing perspective on this, but not very often. So so we should not be sitting around saying, oh, they forgot about us.
Right.
We should be saying, we can't let them forget about us. We need to get out there and talk to them.
It's really important that, not only since our states determine our practice, which is different than physicians, it's very important for us to be active at the state level, but it's also just as important for us to be active at the federal level. We don't have to go to D.C., although that's always desirable. Our congressmen and women are in district, during all of their recesses, and we can always make an appointment. And, in fact, it's often easier to see them when they come back to their own district. And also to maximize or leverage some of what we have. For example, there, I believe, are only 2 nurses in the House of Representatives, or it could be all of Congress. One is Lauren Underwood, Representative Lauren Underwood, who is from our area here in Illinois. And there is a event coming up that was arranged by, I don't think it was ISAPN, I think it was ANA maybe?
IAA.
Yes. And, I think that to have dialogue with her about what our key practice issues are would be very, very helpful, because she herself is a nurse.
Yes.
And she speaks about that.
Yes. And you've so eloquently put that in the context of patient care and what it means when we're all sort of faced with communities where there are social influencers of what's happening, how important that is as the government now continues the debate about health care at a federal level. So thank you. That's great advice. So let me ask, and I'm going to ask you to speak to one of the examples that we were discussing as we gathered here this afternoon. If you could, from each of your respective practices, provide examples that describe the implications for patients and families and the healthcare public in general when advanced practice nurses are identified as mid-level providers. And if I can just sort of add a caveat to that, we were talking a minute ago about sort of the insidious places where this happened. So if you could speak to the examples around schedulers, sort of how that looked. And the instruction for those of us as nurse leaders is to sort of ferret those out within our organizations and sort of fix those insidious places where this happens. So, Angela, could you start speaking to one of your examples here?
I'll share. This is Angela. So this is an example that happened to me just last week. I had to call and make an appointment for an annual exam, and I go to a practice that has many, many nurse practitioners. And from my perspective, the most important thing was the time and date. So I called and said, it's time for my annual. I can only come in on a Thursday. Who's available? I'll come see whoever. And the receptionist or the scheduler on the phone dropped her voice and whispered, well, you can come in on Thursday, but you'll have to see a nurse practitioner. And I said, great, I am a nurse practitioner. Of course, I'm fine with seeing a nurse practitioner. Why do you need to whisper about this? And why you're implying by your tone of voice and the way you deliver this, you're implying that this is a bad thing. And it made me think, if you're doing this to me, and you know I've been going to this practice for a long time, you know that I myself am a nurse practitioner. So why would you say that to me? First of all, it's insulting to me as an individual, but it also sends the wrong message to all the thousands of patients who come to this practice, most likely because they choose to see a nurse practitioner. So that's an example of why it's important to bring this education to the public or the message to the public, and as nurse leaders, we can maybe use that as an example when you're talking with your own staff and your own organization, like, don't do this.
Yeah, exactly.
This is an example of what not to do when you're talking about nurse practitioners. Instead, you should offer, again, data-driven, measured responses, remove the emotion. I mean, even her dropping the voice and kind of whispering, it put in that sense of fear, like it put in something that is, like you said, insidious, and it's not helpful at all. I think overall what it does is it erodes trust in the providers. It erodes patient trust. And then that gets to, if we're talking about our oath of our practice is to first do no harm to our patients, then regardless of whoever's on the phone, that's a common value that we all have in healthcare. So by people who are perpetuating this negativity about nurse practitioners, they are causing harm. They're causing patients to not trust their care providers, which then patients, if they don't trust the person who's providing the care to them, they might not want to adhere to the treatment plan, which can cause harm to them. And it just kind of cascades and can have a really big impact, a big negative impact. So we have to change that. That's all I have to say.
So this is Rachel, in my internal medicine practice, which I left in December to be at the 2 school-based health centers, I actually had multiple experiences where patients would angrily come and tell me, do you know that the schedulers feel that they have to inform me that you're not a physician? And what they told me is they would say back to the scheduler, don't you think you should see a physician? And they would tell me that they said back to the scheduler that, in fact, no, I see Rachel, she's my nurse practitioner, and she's the person that I want to see. And they would be very upset with me. I would encourage them to go onto the website of where I was working to put in a patient comment. Because I think that re-education is really, really important. If we can re-educate people to approach patient interactions a certain way, to approach even things like if there's water on the floor to, inform someone so the patients are safe, we can also re-educate them to not put in their own 2 cents about what's happening about the provider that a patient is calling to schedule with. It's not appropriate, and they're not informed to do that, and it's not their role, and it's incorrect. My patients were calling because they want to see me, and to try and convince them they should see someone else is not what should be happening when the patients are calling.
And I think, this is Terry, I think conversely, a lot of times people think that nurse practitioners are masquerading as physicians. You're trying to pass as physicians, where I make it clear to all my patients, I'm a nurse practitioner. I work with a population that has a distrust of the healthcare system, that they often are hesitant to seek out any care. And so once I'm able to establish trust with them, I get asked, so what does it actually mean that you're a nurse practitioner? I educate them about the profession, and then it's really interesting to see, a connection being made. So if I refer them to a specialty and they're hesitant to go and they say, I've never had a good experience and I'm scared, but then they'll go to the specialty and they'll say, oh, I met, the best provider and I can't believe that I've now met 2 providers that, I can trust. And I thought I was seeing a physician, and then when I asked, it turned out it was a nurse practitioner. So I think it's really important to educate our patients that we are different from physicians. Our ideology is different. Our theories are different, and I think it impacts the care that our patients receive in a really positive way.
I think you have addressed this perhaps in a number of the other comments that you have made, but there are, periodically you see popping up in the literature where some organizations are choosing a different term, right? So they are still sort of clustering advanced practice nurses with other caregivers, perhaps thinking that it's less offensive, a title, than mid-level. So I think about some of the titles, for example, associate provider. Is this a practical solution? And does that sort of continue to perpetuate the problem that we've been talking about? And I wonder, Terry, if you could sort of start the conversation, because earlier on you talked about we get to title ourselves, right? like who doesn't?
Correct.
Who sort of looks outside of a discipline for someone to name our discipline?
Yeah. I mean, I would love to pick a different name for physicians, let's say, but
it's not going to happen.
Nurse provider.
And it was really interesting on the comments to our letter. A lot of people were commenting saying, I agree, mid-level is not an accurate term, that they should be called non-physician providers. And I think we around the table all agree that we have chosen a name that we would like to be called. It is nurse practitioners. And I think any other term that attempts, to group different professions together is lacking and is not accurate.
And confusing.
It is.
Mm-hmm.
It is. Here at Rush, it's been a long time since the term mid-level providers has been used, and unless it's been used by certain individuals, but for the most part, no. The chosen term here is advanced practice providers or advanced practice professionals, which certainly is more tasteful than mid-level provider. However, the term still means that we are, as nurse practitioners, we're put into the same bucket as physician assistants. And staff then start calling everybody an APP. And they use that term in front of patients, which can be very confusing. The patient has no idea what an APP is. So it's, I try, and I may say it more loudly than most, but I really emphasize the fact that I'm a nurse practitioner. And I could be standing next to a PA, but I will say, I am a nurse practitioner. And I expect that PA to say, I am a physician's assistant.
Yes.
That's my title.
Yes.
We have titles, so use them.
Yes.
Mm-hmm.
Yep.
You're here.
Yes. Yes. So, sort of one final, I'm going to ask a question and then would love for all of you to comment on this. I could not imagine, and on behalf of Donna Nikitas, our editor for the Journal of Nursing Economics, could not have imagined a better way to kick off 2020, the year of the nurse and the midwife. And to be hosting this podcast at Rush University, who up and down the hallways as we walked into the conference room are pictures of Dr. Luther Chrisman, who was such a prominent leader, both here at Rush University, the hospital as the chief nursing officer, and for advanced practice nursing, sort of at the very beginning as we began to sort of develop this role. What a powerful place to be hosting this call today. As we celebrate the nursing profession in 2020 as the year of the nurse and midwife, what message would each of you like to share nationally and globally about advanced practice nurses? So, Lynn, if we could start with you.
Sure. Well, I came here. I'm the oldest of my faculty colleagues here. I came here over 39 years ago because of Luther Chrisman. And so I knew him well. I worked with Luther. Luther felt that the most highly educated individuals, he would say, should be at the bedside. But now we would, broaden that to say in any practice setting, obviously, the most highly educated individuals, which is why, it's most desirable for nurse practitioners to be doctorally prepared. I believe that. I heartily believe that. I think that puts us on peer with our physician colleagues, our PharmD colleagues, our physical therapy colleagues, and everyone else. So I strongly believe that Luther's philosophy is so true to this day, and it's why we're here.
Thank you. Rachel?
So what I would like to make sure that everyone, both our colleagues as well as the general public, remember is that as a nurse practitioner, I'm a nurse first. So the fact that I'm a nurse is the way that I approach not even just patient care, but pretty much everything that I do. don't remove the nurse from nurse practitioner, because I am a nurse first, and that guides everything that I do from that point on. So the advanced practice that I have learned and that I've perfected hopefully along the way, I have always stood on the basement of the fact that I'm a nurse, and everything I do is through the nursing lens.
Thank you. Angela?
So I would say I have kind of a two-part message. The first would be to kind of talk about what Lynn was talking about earlier, is to get out from preaching to the choir. We have to, of course, nurses and nurse practitioners, we all agree, we know that we're critical contributors to the healthcare system, and some of these stale questions and conversations about what we should be called and do we belong, are we peers and things like that, we know that those are old. We are here to stay. We are part of the team. We are critical parts of the team. And so my hope is that through our work and some of the larger work is that we can help get this message out to the public to help shape the public discourse so we are talking with rather than being talked about. And so my message to nurses is that we have a voice and that this is how change occurs. When we bring our voices together, we can do that. Just like the editor from Becker's said, you have changed the way we're going to report about nurse practitioners. That's pretty powerful. So that's the message. And then the second thing I would want to say is to patients and people across the country is that we are here, we are ready to work with the healthcare team. We are part of it. We are equal partners in their care. Thank you. That certainly was the word. And that we want to help them meet their healthcare goals.
Thank you.
Yeah.
Terry?
Yes. So one thing that we learned in the op-ed project is the importance of owning our expertise. And I think nurses a lot of times tend to be very humble about their work that they do, but that's often to our detriment because we're not speaking out about our knowledge base. And so I would want all nurses to own their expertise, not be, intimidated to speak to leadership of their institutions, to policy makers, and then also to celebrate each other and celebrate yourselves for all the work that you're doing to improve healthcare and patient outcomes.
Thank you. Well, a very, very powerful message from our colleagues here at Rush University. There's a few things I'd like to add before we wrap up our podcast today. The first is to draw everyone's attention and to invite you to take a look at Donna Nikitas' again, the editor for Nursing Economics. She has a beautiful, eloquent editorial on this entire topic. So sort of situated within the year that we are celebrating, 2020, the Year of the Nurse, and really celebrating and congratulating our colleagues here at Rush University for being such outspoken and courageous leaders on this topic. Also, we intend at the Journal to not just leave things here. Over the course of the next year, this next editorial year, we will be citing our colleagues who do have courageous voices around many of these topics. And also, the Journal has put a call out to our colleagues across the country to submit articles to the Journal for consideration under the notion, what would the world be like without nurses for a day? Sort of, what would the impact be in the world globally if suddenly there was a day without nurses? So I encourage you to, first of all, think about that, have conversations with your colleagues and leaders across the country, and consider submitting something to the Journal for us to consider. Ever since that call came out, lots of sort of interesting conversations popping up. The other thing that we will continue to focus on in the Journal this year is the op-ed project, and we'll be coming back to our colleagues here at Rush for your opinions and expertise around that. It works. Please have those courageous voices. It really does make a huge difference. So would like to thank all of you this afternoon and conclude our podcast. Thank you.
The Nursing Economics podcast series is owned and produced by Genetti Publications, Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Dr. Lynn Braun is Professor Emerita at Rush University in the Department of Adult Health and Gerontological Nursing and a consultant in the Rush Heart Center for Women, where she was a nurse practitioner. Dr. Braun's clinical and research interests include cardiovascular risk reduction, exercise, cardiac rehabilitation, hyperlipidemia, and hypertension management. Dr. Rachel Ferry Rooney is an adult nurse practitioner with over 20 years of internal medicine experience and currently practices clinically in 2 school-based high school health centers in Chicago. She is an assistant professor in the Department of Adult Health and Gerontology Nursing at Rush University. She is on the board of directors of the Illinois Society of Advanced Practice Nurses, which represents the professional interests of advanced practice registered nurses to state government in Illinois. Dr. Terry Gallagher is a family nurse practitioner and the director of generalist education at Rush University College of Nursing. Dr. Gallagher established a community clinic serving a low-income community on Chicago's West Side 5 years ago. Dr. Angela Moss is a faculty nurse practitioner, assistant professor, and assistant dean of faculty practice at Rush University, where she leads over 40 community-based faculty nurse and nurse practitioner clinicians providing care to Chicago's most vulnerable populations. Dr. Moss is an expert in the care of underserved populations through nurse-led programs, strategic development of nurse-managed care delivery models, and programmatic and outcome evaluation, and currently practices clinically in a nurse-managed health center for formerly incarcerated men and women. Dr. Therese Fitzpatrick is the Senior Vice President, Performance Improvement at Kaufman Hall & Associates, Skokie, Illinois, an Assistant Clinical Professor at the College of Public Health, University of Illinois at Chicago, and a member of the Nursing Economics Editorial Board. For archived episodes of this podcast and to learn more about nursing economics, visit the journal's website at nursingeconomics.net. You can also subscribe to the Nursing Economics podcast on iTunes, Google Play Music, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and other various podcast delivery services. And remember, as a listener, you can save 50% off your first-year subscription to Nursing Economics. Simply visit nursingeconomics.net/offer to take advantage of this special discount.